delighted to be kicking off this refreshed BRC seminar, Early Career Research Seminar Series, and I'm very grateful to Sarah and Carol who have taken this on. This is the first of what will be, it's almost every fortnight sessions. There with a large content that Carol and can kind of give you an overview at the end. But I thought we'd start off with this one, developing a good clinical research question. So my role is, I'm the Deputy Director of the Leeds BRC. I also have a chair in applied health research. My research is predominantly, as you'll see, related to foot and musculoskeletal disease, and that will absolutely make no apologies for that colouring some of this presentation. But I'm also the Associate Dean of the NIHR Academy and know quite a bit about the NIHR Academy schemes, and really are keen that, that we make the most of those opportunities. So what I'm going to talk about today is basically around developing a good clinical research question that's going to be funded. So it's important that you get the right question, get the right methods, get the right funder and the right scheme, and get the application right. So that's basically what we'll be talking about. So the first and probably the most important question, and I'm absolutely delighted that so many of LTHT people are here, because one of the key issues I think is that having clinicians do research is incredibly important, because clinicians ask smart questions. And so wanted to talk about how you can make sure that you've got the question right. This now is, 11 years old, but it's still, I think, a really powerful summary. It was done by Charles and Glazier and published in The Lancet, and it talks about research waste. And what we're going to focus on is the first two elements of research waste. These are the things that you can absolutely try and avoid by asking the right question and making sure that you've got the right methods. The other two are more around whether or not it's actually able to be published, and I don't want to focus too much on those. But it's not surprising that when these guys looked at what they called research waste, that a lot of it was just people not asking the right questions and asking questions that were important to patients, not asking questions that are important to the clinicians, not even looking at the literature, and not kind of doing things to make sure that the research methods was appropriate to answer the questions. And so I want to focus a bit on that tonight. And really, it is like a jigsaw puzzle, but it's all around getting the pieces right. And so we're going to focus, I'll just run through some of these areas here. Particularly important, it's around the clinical need, what you're going to look at, where the gaps are in evidence, and that's around getting the question right. Then it's around the right methods, having access to the right infrastructure, resources and expertise, and the impact, the so what factor of your question. So when we're talking about developing a clinical research question, it's really important that we understand what the impact of this question is. And that's really talking about maybe the prevalence or maybe the burden. So these two photos are a great example. So if we talk about the prevalence and impact of knee osteoarthritis, knee osteoarthritis is incredibly common. It's, more than half the population over the age of 50 will suffer from knee osteoarthritis. The number of joint revisions, joint replacements is increasing at an exponential rate, and we know that that's to do with an ever obese, multi-morbid population. So the actual cost to the NHS and is quite significant. So it's quite easy to write about the burden of knee osteoarthritis. But when we look down at the lower picture, which is a necrotic toe from someone with scleroderma is considered to be a rare disease. So if you're looking at it in terms of the prevalence compared with knee osteoarthritis, it doesn't compare. But scleroderma in just under 40% of people is a pretty difficult disease to manage, and it results in multi-system failure, organ failure, and it has a huge economic, societal and personal impact. And it's around being able to sell the idea that each of these conditions are important in their own way. It's really important that it's not just about identifying something as a problem, but whether or not something can be done about it. And importantly, will it help? And I'll kind of go into these, talk about these issues a little bit more. Because I think it's kind of easier to talk about the kind of pitfalls that you need to avoid. And I think particularly if you're a clinician who doesn't necessarily have very much research training, you may have kind of a research question, but it may not actually be a research question. It may be more of a long-term goal, and it's absolutely around trying to make sure that you're doing things that will address a research question rather than something that is perhaps not attainable. Vaccine for COVID kind of comes to mind. I'm hoping that that's not quite the case. So a couple of examples. One of the things that's really easy for clinicians to do is to focus on what clinicians do rather than what effect that it has. And I bring you this fabulous diagram, which is from my absolutely disgusting master's project. I'm embarrassed about my master's project because I was a podiatrist, and I was one of, bizarrely, the first cohort to go through with a degree, and a lot of what we did back then was to draw lines on people and measure things, and we thought that by measuring things that we would be able to do things like make orthoses, orthotic devices that would control how people walked in a very precise manner. And by the way, this isn't just something that happens to podiatrists. I know physiotherapists and occupational therapists are just as bad as kind of focusing on measurement. And so I spent too many years of my early life trying to work out whether or not clinicians could do this reliably. And guess what? They can't. And who cares anyway? Seriously, who cares whether or not clinicians can measure things and do it reliably? What the more important thing was, do orthoses have an effect on pain, on disability, on functional ability? And it took me quite a long time to get my head around that. And I think that was an indication of my naivety in terms of research naivety, and it was also kind of focusing on the profession. And I'll absolutely say most large organisations will not fund a profession-based, so they won't fund nursing research, for example, or they won't fund physiotherapy research. They will fund nurses doing research into X condition, or physios doing research into Y condition, or cardiologists doing research into Z, but they are not interested in kind of something that just kind of plumps up the professional organisation. So it's really important that you're focusing on the effect that it has, particularly on patients. Really important question is to ask yourself is, do the patients or do the NHS or the organisation want it? And one of the programs that I was involved with is around a fairly rare genetic condition where young children produce a lot of mucus, and was working with a fabulous physio who was really keen on doing research into this area. And we initially was thinking that if they did some kind of percussive assessments that this, similar to cystic fibrosis, may actually help. And when we asked kind of whether or not the patients want it, the patients absolutely did not want it, because you had kids who were producing lots of mucus, and who were kind of snotty little kids that were not necessarily socially integrated in the playground. And what you were doing is producing more mucus and making them even snottier. And it's not what the patients wanted. And even though it may have had some kind of long-term effect, it was always going to be difficult to get patients to buy in. Similarly, we see a lot of people wanting to do research in, and I think the classic one is around knee osteoarthritis. So we see quite a few studies that have looked at the effect of, say, like the ESCAPE study, where if you have weekly sessions with the physiotherapist, your knee pain will improve. The trouble is that the NHS won't be able to fund weekly sessions with a physiotherapist. And so you need to ask yourself whether or not, so as a concept, and I think the ESCAPE trial is a great example of, they needed to ask that question, but what ESCAPE have been very good at doing is looking at how you implement that in terms of what's available and what's going to be practical according to the NHS, because they're certainly not going to see every patient with knee osteoarthritis weekly for a 12-week period. The other thing is just the bleeding obvious, and the BMJ do a series, it's around Christmas each year, where they kind of have not fake articles, but they do have articles that are probably a little bit more on the interesting side. One of my favourites was what actually happens to teaspoons within an academic institution. And it's things like this. Yeah, no, we absolutely shouldn't be using parachutes because there's not been a randomised control trial done. And I think there is some issues around just obviously things will help, and researching them doesn't seem to be, isn't a good investment of money. The other thing that you need to be careful of is things like the bleeding obvious in terms of exercise. And the chair of the Research for Patient Benefit committee was really clear that he was absolutely sick of things coming, the effect of exercise in cardiovascular disease, the effect of exercise in scleroderma, the effect of exercise with mental health. And it's kind of, we know that exercise is good. We know that there's enough evidence. So just kind of looking at doing it in another condition isn't necessarily novel. What certainly for someone who's involved in osteoarthritis, the things that we want to know is, how do you get people to comply? What motivates people? What will make sure that people will do the exercise? So just kind of having an obvious thing like the effect of exercise in a particular condition probably isn't enough to get funding. There's also the meaningful, so well-meaning but absolutely impractical. This is one of my favourite studies. It's night splints for people with plantar heel pain. So this was a very small study done where they put this kind of, it could only be described as an instrument of torture on 16 poor people with plantar heel pain, and followed them for 3 months. And guess what? Only one of them actually finished the trial, the 3-month trial. Almost all of them reported adverse events, but across the board, all of them, because it was a night splint, all of them reported fairly significant sleep disturbances. And again, it's kind of not really thinking about the practical implications of the actual treatment and how it's going to impact on patients. And there's also the well-meaning but so what. So a lot of my work is in foot orthoses, and we've done a lot of work looking at customised devices, the effect of customised devices, which absolutely have been demonstrated to have an effect on certain conditions, versus less expensive off-the-shelf devices that are mouldable. And the number of podiatrists who come up and tell me that the reason that their orthoses, the orthoses that they make, are so much better than anything else that's around. It's just absolutely ridiculous. So they think that something that they're doing is going to be slightly different. And again, unless you can actually demonstrate that there is a change, it's kind of, again, the so what question. Another key element of refining the question is looking at the evidence, and this is again what we were talking about with research waste. And the evidence, obviously, in where we're talking about hierarchy of evidence, systematic reviews and meta-analyses are kind of the gold standard. And so Systematic reviews and meta-analyses are great when there's been a large body of work. So, for example, in foot problems, we have lots of systematic reviews around plantar heel pain because plantar heel pain is incredibly common and there's been quite a lot of research done into it. But in a lot of other areas, and I know that this is the same in some of the more emerging professions, is that there's not enough evidence to actually do a systematic review, and this is one of my favourite systematic reviews, which is basically the effectiveness of dry needling on my injections on trigger points with plantar heel pain. They did a systematic review knowing that there were hardly any studies and knowing that the nature of the studies were poor, and so the results of the systematic review were basically there's not enough evidence. And sure, the people, you know, Matt, who I know very well, he got systematic review experience out of it, but I guess it's why bother doing something that you know that you're not going to find much evidence for. And this is where narrative literature review is becoming increasingly important. When we talk about the grey literature, particularly in areas that don't have a strong evidence base, they're incredibly important. And, you know, so it's good to actually look at not just, you know, the systematic reviews, but the wider literature. And that can be, so clearly not just Nature, but less highbrow journals, and certainly things like NICE guidelines. So things that, you know, are not necessarily, you know, your gold standard literature. They can also help and provide you with lots of information. And clearly they need to be considered in light of the, you know, the strength of the actual information and the research. The other key thing is to talk to those people in the field, and this slide just includes a lot of people that work with rheumatologists, biomechanists, radiologists, radiographers, mental health nurses, biomechanists, so various scientists, so a very wide range of people. And you should also be talking to not just the people who are researching there, but also clinicians in the field. And clinicians who are expert, who kind of get, you know, have a very good insider knowledge of what it's like to both live with or to treat conditions. The other key people to talk to are patients. And certainly for most funders now, the meaningful patient and public involvement will be central to the development of any good clinical research question. And here at Leeds, we're very lucky. We have a very strong and active cross Leeds Teaching Hospital and the University Patient Public Involvement Group. I know there are some people here from Bradford and the ARC, and they also have very strong patient public involvement. And it's incredibly important that this is done properly. The worst kind of PPI, for example, is just you as a clinician asking your patients about how they think about a fabulous question that you've got. That's completely inappropriate. It needs to be done in a structured and meaningful way. And there are resources here at Leeds that will be able to help you. There's a session that's scheduled on PPI in this series that Carol will be able to talk to you about. The other thing is look at the James Lind Alliance. And the James Lind Alliance is an incredibly important group. I'll see if I can bring up, they have, they're basically a partnership approach to prioritising research questions, and they've done prioritised research in a number of different areas. And I'll just see if this will come up. Can you see that? I don't think you can. So, but they've got a wide range of research from chronic obstructive airway disease to dermatitis. So if you haven't done PPI, then go and have a look at that website to see what they think is important. The other people who are important to talk to are the people who are potentially funding your activity. So whether it's the commissioners, whether it's the CCGs, whether it's some other funding organisation. So make sure that you're talking to the people who are the different stakeholders in the actual question. And by doing that, you can refine where the gaps are and how important are these gaps and what needs to be done in those areas. So that's kind of the summary around kind of a fairly comprehensive systematic approach to looking at how you're developing a question in a particular area. Central to developing a question is making sure you're getting the methods right, and the right methods really need to kind of support your question. And if you're looking for public funding to support a research question, clearly they are going to look to make sure that it's high quality methodology, so that you start out with a research question and that you're using the right methods to actually ensure that you're answering the question. And I think when people start, what they often start off with is not a research question, but a goal. I'd like to change how a clinicians diagnose diabetic foot infections. And that might be your long-term aim, but what is the research question? What's been done in the past? For example, one of our PhD students at the School of Healthcare is looking at, whether or not, how people make the decisions that something is infected or not, and do different clinicians make those different decisions? So it's important that you have a research aim, and the research aim generally tends to be a wider kind of the aim of the whole group, and then it's broken down into smaller objectives. And one of the most important things that you'll start with is, what is it that you want to measure? And this is really where, when you're, instead of trying to have this long-term goal about making clinicians better at diagnosing diabetic foot ulcer, that you're drilling it down to what is it that I want to measure? What kind of things do I want to have an effect and change? And this is where we talk about primary outcomes and secondary outcomes. So it may be that you might want to do some biomarker work, or you may want to look at some kind of imaging as an outcome, or something like gait analysis, or you may want to look at patient-reported outcomes. So it's important that you're looking at measuring. And again, another pitfall to avoid is just because you can measure it doesn't mean you should. And one of the things when we're developing protocols is we absolutely need to look at is the burden on the patient. Yes, it would be great if we could bleed every patient of several litres of blood to see different biomarkers every 4 weeks, but it's just not appropriate, it's not ethical. Yes, we could get them to answer 24 different questionnaires, but again, that's inappropriate and it's not structured and not strategic. So have a think about what it is that you're trying to measure. And things like the primary outcome, if you're looking at quantitative studies, it's incredibly important. And the primary outcome is important because you need to make sure you're measuring what you think you're measuring. You need to make sure that it's a valid and it's an appropriate measure. It has a huge effect in terms of things like numbers you need in terms of if you're developing a clinical trial. It needs to be clinically important. So who cares if you can determine a change, but if it's a change that patients can't measure, it doesn't matter. And again, making sure it's relevant and not too burdensome on patients. For each of the different methodologies, there's kind of a framework and there will be rules around this. So for example, in clinical trials, there are different stages of clinical trials. So there's the early concepts, early studies where you're developing a pre-patient, which are around about proof of concept, and then it's around introducing into patients. So there's a human safety and expanded safety, and then it's around the efficacy, clinical and economic efficacy. And it's important that you know the different rules of engagement for things like clinical trials, and there's a wide range of literature to assist in that. Similarly with qualitative approaches, again, there are frameworks of how you approach qualitative methodology, which is very different to the quantitative, but still there's an issue. And again, it's really around making sure that what you're doing is credible, is repeatable, or is at least transparent, is analysable, and again, it's useful. So you need to make sure that you're engaging with the right approaches that support your question. And again, it's around having appropriate frameworks. And so, as I said, there are lots of tools to help in you developing the right methodology. And these are around whether or not you're talking about a clinical trial, whether or not you're talking about a public health issue, or qualitative research. So there's lots of information around there, and you need to be directed to the right people and the right resources to help you develop that. And think about it in terms of your clinical development. You know, this is an area where you might be very experienced clinically, but you will have no framework in terms of the methodology, and this is where you need to get help. The other things to avoid is making it simple. If you're doing some kind of project that's very complicated, it automatically introduces an element of risk. It's like, well, are you sure that you're going to be able to repeat this? What happens if this doesn't work? Are you going to be able to do the next phase? So simplicity is very important in terms of making sure that you're able to articulate what it is that you're trying to do. And again, it goes back to the so what. You know, why are you doing this research? Is the methodology, is it the right question? Is it the right methodology? And a way of actually looking at the so what is to look at the impact. And the impact has become incredibly important. And a lot of funders will actually ask you to articulate what the impact is. And I'd strongly suggest that this type of approach, no matter what kind of research that you're doing, is incredibly important. And what it gets away from is just doing research for the sake of doing research, and what you're actually saying is that, you know, what is the planned work and what are the short and long-term objectives. And this becomes incredibly important in terms of the university around the Research Excellence Framework, because we actually get funding based on the impact of our research. And some of the times, and I'm a classic example in that we did some work it was 25 years ago, looking at prescribing habits of podiatrists, and we did a survey, and we've been able and that was just, we were doing it because we wanted to know what were driving clinical decision making for podiatrists, and that's actually been a very useful instrument to look at how people have changed their prescribing habits, and so the impact of that is actually good. I'd love to say that was pre-planned, that was just luck. I think now we can't rely on luck, so it's around, I guess it's like, what are you trying to change, and can you measure the baseline of before you do your research? Can you measure what are the things that you would like to measure, so that when you look back on the long-term impacts, how that will work out. And most importantly, it's talking to the right people, and it's absolutely the way of the world. Methodologists, health economists actually absolutely rule the world, and we're fortunate enough to have lots of very talented people who have expertise in several different areas, and you absolutely need to include them as part of your research team. You absolutely need their guidance in terms of the research design and your methodology, how you're going to analyse the information, and what you're going to do with the information. And these are key people within your team. incredibly important people to include. And also important is around getting the funder right, and people just seem, I just very much worry that people have this very scattergun approach. They've got an idea, they're going to try and get it funded. So, I've just realised I've got the old Arthritis Research UK, it should be versus Arthritis. So these are just a number of different organisations, and quite clearly, Diabetes UK are going to focus on diabetes research. That's obvious, but have a think about what it is that they're focusing on. What are the drivers for Diabetes UK? You absolutely need to understand what their strategy is and what are the things that they're going to focus on. So Arthritis Research UK, for example, which has now become Versus Arthritis, did a lot of work around their strategy, and they are very much embedded in pain and pain research, and have moved away from a lot of the biomarker research. So if you try to put a biomarker research project within Versus Arthritis, it's going to be a difficult sell. You're much more likely to get biomarker research either funded through the MRC, or if it's validation and not development, maybe through the NIHR. Leeds Care, which was the Leeds Charitable Foundation, clearly, because they're a Leeds-based organisation, the kind of things that they're going to be looking for are going to be about how the Leeds city and how the Leeds Teaching Hospital Trust will benefit from your research, and how the staff, or how you will benefit as a staff member. And clearly the Commonwealth scholarships, while I'd like to think this was for me to go back to not Melbourne at the moment, but I'd probably like to go to Perth, you know, on a scholarship. The Commonwealth scholarships, when you look at it, if you have a think about the public investment, they are looking at the Commonwealth countries who require more of a assistance, you know, with their research. So they're looking at people who are coming from low and middle income to participate with the Commonwealth scholarships. But the most important thing is that you need to understand what the remit of the strategies of the funder. And I'll give you an example, and this is because I know most about NIHR. For me, NIHR remit is actually really straightforward, because when you think of where the NIHR came from, the NIHR it's absolutely Department of Health. It was Department of Health funding. And in 2006, up until 2006, every hospital, every trust within England was supposed to spend 1% of their budget on research. And it didn't matter whether or not it was a large hospital like LTHT, or whether it was a smaller hospital. And when they reviewed what their money was spent on, it was spent on lots of things, but not strategic research. It was being spent on research administration, or it was being spent on small N=20 trials, which made absolutely not one bit of difference to patients. What they tended to do was fluff up people's CVs, but again, there was no strategic oversight of how all of this funding worked together. And so that's when, in 2006, Dame Sally Davis said, right, 1% of the NHS budget, that's around £1 billion a year. So we'll create the National Institute for Health, the National Institute for Health Research. And again, think of this is Department of Health funding. So it's being taken away from the frontline NHS services, and the whole vision is to improve the health and the wealth of the nation. So if you're thinking about that, if you want the NIHR to fund something, it better be good, and it better be important to the NHS and important to patients. And so in 2006, the National Institute for Health Research was born. This is the diagram, and you can see that it invested a lot in people, so that's the faculty up the top, in infrastructure like the clinical research networks, the clinical research facilities, in management information systems and ethics, in research projects, and also in research infrastructure. And you can see that at the heart of this are patients and the public. And importantly, it's patients and the public within NHS trusts supported by the universities. And that's a really important distinction. So, for example, the BRC, the funding, the £1.7 million a year funding actually goes to the trust, and the trust then gets some services off the university. But it's a really important distinction, and it's really the emphasis is placing patients absolutely at the heart of research. In the intervening years, the Department of Health has actually become the Department of Health and Social Care, and the social care and public health is a really important part of the NIHR agenda. There's a lot of work going on to try and support this, and this is now the new diagram, but you can still see that it's investing in infrastructure, it's investing in patients and public involvement, it's investing in people, it's investing in partnerships with industry, and it's supporting high quality work. So importantly, you must do your homework. There's no point, and you often see people write a grant and they put in the same grant for different funders, and I will guarantee you it will not work, because they each have slightly different language, but importantly slightly different strategies. And that's why they're not replicating one another's remit. So do your homework, look at other successful grants and read the instructions. If you're going to them, for example, for, £250,000, which is not a very expensive grant, how dare you not read the instructions? I keep saying that to the PCAF guys, so hi PCAF guys I see here, but how dare you not read the instructions if you're asking for so much money off them? So it's absolutely just really straightforward to do that. It's important also to understand the difference between different types of grants. So project grants are usually small, discrete pieces of high quality research. So there might be things like a randomised control trial or something around a service delivery redesign. So they have a beginning and an end, and they are not reliant on other research and other issues. By definition, they're slightly smaller than program grants. And program grants are usually, it's a program of work. So there will be often several different elements that will be around an umbrella goal or aim. And these usually are between about 1.5 to 2.5 million pounds, so that we're talking about large investments. These program grants take around about at least 12 to 18 months to develop, and they're incredibly competitive, but they should be, because it's quite a lot of money. And then there'll be commission calls. And again, the NIHR do a lot of these where they get the great and the good, and not even the great and the good, but, anyone can suggest providing evidence to say, look, this is a really important need in terms of understanding what the issues are. So this has just come off the website today. So it's around partial versus total nephrectomy for clinically localised renal cell carcinoma. Australian collaborations welcome, which means the Australian government are going to put in some money, which is great. A standardised and structured tinnitus assessment in general practice. So they will say, we think that these are important things. Why don't you put in an application around this? It's really, really important for these commission calls, because they have a remit. So if you try and rewrite their question, they will throw it out. But if you write, again, a high quality, with an application that has a good quality multidisciplinary team with the appropriate methodology, they're a kind of a reasonable call to be funded, because the fund have already said, look, we think that this is important and this should be supported. And finally, just a brief mention on fellowships. Now, fellowships are like gold dust, and the reason they're like gold dust is because they're very generous, and they are absolutely around funding the person. So they fund, so while most of the others talk about the project, and they will worry about the, this team and the environment, The fellowships generally tend to be funded equally on 4 different elements. One is the project. 2 is you as a person. So where you've come from, what you've done in the past, what floats your boat, what makes you want to do this, what stage are you at in terms of your clinical and your research activity. They're looking that you're in the right environment, and I'll come back to this in a moment. But importantly, and you never get this at any other time in your life, you get a really generous training and personal development program. And one of the things that we find, again, we suggest that these take 12 months to write, 6 months if you've got a lot of time that you can spend on it outside of or as part of your job. But it's around making sure that you've got all of these things that tick the box for not just the project, but also the person, the environment, and the training and personal development plan. One of the things that we find most difficult is when someone wants to apply for a fellowship and they've only spent their time on the project and nothing else on the other elements that are equally weighted. So it's incredibly important that you understand the difference between the investment in you rather than investment in a project. And finally, it's getting the application right. When we're talking about the environment, it's really around, are you in the right place to be supported to deliver on your research project? I remember reading this fantastic application from an amazing applicant who was talking, and the reason I was reading it, it was around hip osteoarthritis, but the head of department support statement was, yes, this person is great, and we're fabulous at dementia research, and listed all of their information about dementia research. And you immediately thought you're in the wrong place. How are you going to be supported when no one else is? You don't have a critical mass there to help with that. And it was, it was a very, very difficult thing. And that feedback, it just creates too much risk. And importantly, so like clearly, there are different trusts, different universities, and that, for example, the University of Leeds may not necessarily have research in your particular area, but certainly there are other universities, Bradford, Newcastle, Sheffield. We have collaborations, and it's important that you have the right academic partnership to support your activity. Costings are incredibly important, and what I think used to happen is people would make up a figure and then just try and get the costings to match that, and that's completely inappropriate. If you don't have costings for all of the things that you need to make the grant work, you are again introducing an element of risk that you're not going to be able to deliver. And it's one of the things that we find really difficult with people who they want to do a lot, but it's going to cost, it makes the grant too big. So instead of cutting down, they just cut costs. And that's just wrong. First of all, the panels will see that, and they won't support it. But if the panel doesn't see it, then you're just setting yourself up to fail. So it's important that you get the appropriate costings for your grants. And all of the institutions have different people. So certainly there's Beck Savage and the Trust. The university have a whole team of people who will help you do that. So it's important that you get your head around the costings early. And just a couple of key but often missed elements. As I said, know your funder, know your funder's language, know your funder's priorities. It's incredibly important. Write for your target audience. So most funders now will tell you who's on their panel. And so it's really important to write with those people in mind. And that can be really powerful in saying, should I include this information or not, based on can I fit this in? And if you can think of the people, that makes it a little bit easier about, no, I don't need to include that, or yes, because they won't understand it. Keeping the message clear is important, and importantly, avoiding professional jargon, and allied health professionals are just appalling at it. where they kind of seem to make up their own language. You need to be able to speak in a language that is for health professionals and medics. You need to make sure that you're not falling into professional kind of jargon. Importantly, make a professional submission. There's nothing worse than when you're being asked to review 30 applications, which are 80 pages each, and one of the first things you come across are typos that just indicate laziness. It immediately puts the reviewer offside, and if they've got 19 more applications that they can read, it just puts them in a grumpy mood. If you're asking for this much money, then the least you can do is read the instructions and make sure that it's proofread and it's a professional submission. And the importance of a good abstract and lay summary are key. They are the first things that people will read. They set the study, they set the grant up, they give it a context and an excitement, and absolutely help to clarify and to prioritise the research question and the application. And strangely enough, they're often the last thing that's done, and they're done in a hurry. Please, please don't do that. Okay, just some ugly but realistic issues. Most grants have a success rate of about 1 in 5. So it's part of research. You're going to have to learn about rejection. It always hurts, no matter how experienced you are. And what we always do is when we've had something rejected, we read the comments, then put the grant away for a couple of days, muttering to one another about how absolutely inappropriate it is that they just didn't understand what we were saying. And once you get over that red mist, is go back and read the comments kind of with a kind of a different lens. And importantly, is it fixable? A lot of funders will provide you with lots of information, and if they're putting in a lot of information, it usually means that they want to see it again with these changes. Get advice, get someone else who speaks their funder's language to say, I think that they want you to do it, or no, I just don't think this is in remit. And most importantly, don't take it personally. And that's something that if you're getting involved in research, you cannot take the combative rejection process to heart, because otherwise you won't survive. So finally, it's just a couple of quick things. Okay, make sure you're asking the right question and with the right people. Prevalence, impact, cost, patient burden, etc. So on. Homework is essential. Knowing your funders and knowing your schemes and knowing the right methodology for the right question, and knowing that you don't necessarily know all these things at the moment, I think is really important. And just because it's this time of year, it's really important that research to me is a lot like cycling. Geraint Thomas, when he went over the line in Paris in 2018, got all the glory, but it's that team around him, and knowing that he was a member of that team supporting other people and that everyone has a role to play, I think is incredibly important. And making sure that you're giving yourself the right time to make those connections to produce a professional submission is absolutely essential. Any questions?
So, Professor Keenan, thank you so much for that amazing talk, and you've just packed so much into this presentation. We've actually got quite a few questions on the chat at the moment. I'm also aware that time is an issue, and we only advertise that we only have 4 more minutes left. So I'm going to go through. I thought we had an hour and a half. Sorry, my apologies.
That's
okay. So I'm going to go through a couple of the questions, if that's okay. And if we don't get to your question, I think what we will do is we will ask Professor Keenan to answer those, and we can circulate the answers to the group, if that's okay.
Absolutely.
So we've had some really great questions about PPI, and PPI is so important, as we know, about getting the question right. Kate's asked, is there any way that we can get funding to support our PPI in our research programs?
Yes, you can. So the Research Design Service have a funding available. It's competitive, and they will help to actually support, to support that. So I think Dave Aldred has put the link in the website. So RDS certainly does have funding. If you're lucky enough to be doing things in musculoskeletal disease, then you have the infrastructure for the BRC. We also in Leeds have a PPI group for cardiometabolic, cardiovascular, and oncology. So there are access to some groups available, but they're funding from the RDS.
Excellent, and we're going to circulate some of the links. So we're going to circulate the JLA link that you were alluding to earlier, and also we'll circulate the RDS link to everybody as well. Going on with the PPI link, in these strange times that we're all living in, trying to do face-to-face focus groups and actually meeting our patients is quite difficult. Do you know any ways of having some novel ways of interacting with our patient body?
Yeah, so certainly the BRC have been doing almost all of their, not all of them, but almost all of the activity remotely. There are some issues with that. There are some inclusion issues because not everyone has access to, remote opportunities, having the, computers, etc. We are going to do a whole session on PPI, and I deliberately didn't spend a lot of time on it because it's so important to do it so well. And I'm not exactly sure when that's coming up, but I think it's
so not long.
Brilliant. And so it's really important that it's done appropriately. We've been doing a lot of work in Leeds around outreach and around hard to reach groups because we're not unusual, I think, in the Leeds partnership to have a very boring demographic in terms of our PPI activity. And so it's really important that we're looking at marginalised groups, particularly in terms of health inequalities. And so there's a lot of work that's going on in that area. So if you're part of either Leeds Teaching Hospital or the University of Leeds, if you contact either myself or Donna Johnson, we can put you in contact with those people.
Cool. We've had this great question from Lee. So I think Lee's an engineer, and I've experienced this with other groups that I've been working with. They're quite remote from some of our clinicians and want to be involved with research and want to be able to help to be either working within a project or developing research questions. How do professionals that are working in silo, who are not within a clinical environment per se, get involved with working in a research question or working up research questions?
So a couple of different opportunities. So Lee, I'd be interested to know, so certainly in engineers, there's a lot of cross collaborations. So in terms of the Department of Engineering, in terms of the Institute of Medical and Biological Engineering, we have very close contacts with the engineering where we bring clinicians and scientists together. That's a fairly large part of our work. So I guess it's probably signposting you to those different groups. There's a very active health technology group. There's a new centre of excellence that in health value technology that's just being launched. So I think it's around potentially signposting people to those groups and those opportunities.
And I think probably this will be the last question of the night. But again, we will answer other people's questions if we don't get around to you. Is question from Tom, and it's about methodology. And I've crossed this bridge a few times as well. Everybody thinks that methodology should be quantitative, but actually when we're dealing with patients, we have to have that qualitative element. And so we end up with doing mixed methodology projects. how do we find the appropriate person to help us? How do we get that appropriate methodology? And are researchers or funders wanting to fund that kind of work, or is it all about quantitative research?
Depends on the funder. I can certainly tell you that NIHR absolutely loves mixed methods research, I'd be very careful about just doing pure qualitative research, because qualitative is usually around finding about something in depth. And when you're looking at the health and wealth of the nation, the thing that really floats people's boat is when you can look at the impact or the understanding of something, but then do the so what, and so that's where the next methods come. So I think that we know our review of training, the NIHR, it was around about, it's by far the majority of research was mixed methods that was supported. So absolutely mixed methods is supported. It's not just, it absolutely is not just quantitative. Part of the thing I think that gets people, and I'm be interested, I think this might be an issue with Tom, is that some of the time that what we're looking at is investigating whether something works. And that often relies on some kind of quantification, and then goes back to quantitative methodology. Whereas if we're asking a slightly different question, such as kind of how things work, or looking at research, how you're designing services, that's completely different. And so I think it's absolutely around widening out the kind of things that you need to kind of look at, and what kind of questions that you're asking.
Perfect. And I think we're going to end the questions there, if that's okay. But like I said, if we haven't answered your question, or you've got some other burning questions, please feel free to contact me, and we will reply to your questions. I'd just like to do a couple of things before we end. First of all, I'd like to thank Professor Keenan for her time and her enthusiasm, and for this amazing presentation she's given us tonight.